A big thank you to CRDF Global, of course, and the organizers to give me the opportunity to share some of the work that we've been doing in Vietnam with regards to private sector engagement. Today's presentation I have structured in roughly 3 sections, and they are around a bit of a background on TB globally in Vietnam, and then looking into what we call an intermediary agency, or into this what I so boldly termed next generation private sector engagement, and like how we piloted and scaled that, but then also looking beyond just the TB care and prevention activities, but looking at how can we actually shape the market, expand beyond healthcare provision for TB, and then have a few concluding remarks. So just as probably most people here know, but just to recap quickly, TB in the context of global public health is actually still was in 2019, before the pandemic, the deadliest individual infectious vector. There was more so than HIV, and clearly here you can still see other infectious diseases like lower respiratory infections causing more deaths, but TB as the single disease caused more deaths than any other, and is on par roughly, if you count those co-infected with HIV dying of TB, on par with diabetes. Why do we need to end TB? Is this kind of I want to say almost a no-brainer question, but it's always good to come back and just visualize how many people have actually passed because of this disease. And as you can see here from an infographic published by Nature magazine, that over the past 200 years, it's actually been 1 billion people dying of TB. And if you look at the other major infectious diseases in comparison, they're quite a bit smaller. And even though we have this pandemic over the last couple of years, which has claimed almost 7 million people's lives and has for a short while taken over as the deadliest disease, our efforts of developing a vaccine and then distributing and bringing it to beneficiaries, or to people, has actually then resulted in the fact that COVID-19 seems to be actually have been quite short-lived, and in context, in greater context over time, it barely notices or barely registers in terms of the mortalities it has caused. So what is driving TB, or how does it continue to be a problem, if you will? And as you can see here, every year there's about 10.5 million people that fall sick with TB. In 2021, obviously that number, for the first time in a long time, increased due to the COVID-19 pandemic. But if we put that number again into context, this is roughly the population of New York City or Ho Chi Minh City each year falling sick with TB, or even compared to the population of a whole country like Greece. But what is the problem? Technically, TB is a curable disease. So the problem is actually that we don't find everybody who gets TB. And so those comprise what we call the missing case, or the unreached people with TB, comprise the large proportion of people that actually then in the end succumb to the disease. And again, because of COVID, last year registered a spike in the number, or rather a sharp decline in the number of persons that were detected and linked to free TB care, as is the case around many, if not most, countries in the world. And one of those countries that showed a substantial decline in case detections, if you will, was Vietnam. And so if we look closer at Vietnam, here is a 10-year snapshot of the annual treatment coverage, what we call treatment coverage, or the percentage of people that are estimated to have incident TB and then are linked to care. And there are 2 significant events here, as you can see. The first one is that for about 5-6 years, the country thought it was actually doing quite well on its way to actually achieving WHO targets, achieving the goals that it had laid out in terms of ending TB by 2030, until it conducted its second prevalence survey. And that survey showed that we were actually much further off than we thought we were, reducing the treatment coverage rate from actually the estimates from 83% down to 57%. And we've kind of tried to combat that, or try to accelerate interventions to increase that coverage rate, and then the pandemic hit, dropping the coverage rate to below 50% for the first time since the national TB program in Vietnam was established. So if we know that we have a lot of persons with TB that are missing. The question then is, where are they? And there are various analyses, one of them being an onion analysis or a TB care cascade analysis that looks at where are we basically no longer reaching people and with TB. And on the left, you see a bit of a simplified version of that cascade, basically boiling it down to three main categories. The first is the number of people that we reach, the number of people that have TB, seek care, but then aren't reported. So what we call underreported, under-notified persons with TB. And lastly, the people who either have symptoms but do not seek health or don't have any symptoms at all, or know that they have symptoms, know that they have TB, but have to prioritize other things like livelihood generation and thereby forego health seeking altogether. Breaking it down into these three categories, and generally, and this is overly simplified, but there are various answers or various solutions that we can employ in order to reach these people. And particularly if you look at the people who are at the top, who are asymptomatic, who are not health seeking, or what we also call the underdiagnosed, you can implement strategies like active case finding, contact investigation, which hopefully after the pandemic, everybody now knows what that's like, as well as community engagement, advocacy, awareness building, and community health system strengthening. With regards to the people who do have TB and who seek care, but then still remain underreported or under-notified because for various reasons that relate to poor collaboration between government and private health facilities or traditional healers or pharmacies and so forth. There is a strategy in TB, it's called public-private mix or PPM, which consists and has been around for roughly 20 years and a little longer, even 25, and consists of having the government try to work directly with burgeoning and now well-established private sector healthcare providers in order to get them to contribute and to participate in the TB care and prevention activities of the government. As you can see here, some of the interventions that are activities that we can implement are enhanced private sector engagement, providing high-quality diagnostics, integrating primary healthcare and universal health coverage, et cetera, et cetera. One key point here, and this is why we're focusing today on TB, on PPM or on private sector engagement, is that if you have to go into the community and look for persons with symptoms and look for persons with TB or even persons that don't have symptoms, that can become very costly very quick. Whereas the second group, the underreported group, could be reached at a fraction of a cost, since the person with TB does actually most of the work already by going and seeking health, just that you haven't expanded your network to include those places, those touch points. So focusing on PPM and private sector engagement today, we want to look at how did Vietnam do actually in terms of private sector engagement in the past, and how much particularly have healthcare providers in the public sector outside of the National TB Control Program, as well as in the private sector, contributed to the overall response to TB. And as you can see here, PPM notifications or notifications from these non-state providers that are within the TB program have been roughly 12% of the annual 100,000 that are notified. Of those, 9% are from other state actors that are general health hospitals or other specialty care providers outside of the pulmonary system or respiratory system. And then finally, only 3% came from the private sector. And that's in part because if you now look at this actually quite busy landscape, there are just so many touch points where somebody with TB symptoms or somebody with TB can actually seek help. And I've circled a whole bunch of them. And again, I apologize that the slide is so busy and complex, but it's in part to reflect how actually complex it is for the National TB Program to manage the response at the national level to this epidemic. And so some of these circles that I have in here, we will dig a little bit deeper into, and particularly those revolve around the first group on the left side, which is the non-NTP public and private hospitals, the private practices and clinics, the polyclinics or monoclinics, as well as even some of the drug retailers and pharmacies. That is what I will look at in the first section. But then, as you can see here, all the way on the right, there are other stakeholders or other players in the landscape of TB and other entities that could technically contribute to TB care and prevention, but for now have just not sufficiently been engaged. And so that would be the second part of this presentation. But without further ado, going into this quote unquote again, next generation private sector engagement model, the concept of an intermediary agency is pretty basic. It's what we would all know from if you want to go buy a house, or if you want to go rent an apartment, you find a broker, because they know where it is and they are able to link both sides and establish this common basis of trust, or common basis at least of understanding. And so these intermediary agencies, they have been around obviously for a long time for different sectors, but for TV, they came about roughly 10 years ago, funded largely by the Bill and Melinda Gates Foundation for 3 sites, 2 private or 2 NGOs and a public site in India. And it's shown that if you employ this intermediary agency, or this third party, this link between your key actors, and offer both sides a tangible value proposition, particularly the private sector, such as medicine, such as diagnostics, or even human resource support, technical assistance, and even incentives, it can actually get more private providers interested and engaged and integrated in the public health response to TB, which then has shown in India to generate long-term and sustain, and this is the important part, sustained increases in case notifications, as can be tracked over the last 10 years from what India, the country, has reported to WHO, to the point where today, this model actually has begun to transition from external funding to state funding in certain states, as you can see here, Uttar Pradesh, which is in the north and one of the largest or most populous states of the subcontinent. So we took that idea and that model and tried to see what we could do together with the National TB Program to adapt it, and what we termed as PCPS, or proper care in the private sector. But it was basically built around the value proposition for non-NTP providers of somebody else. I took this basically from somebody else, but it's labeled as the 6 R's. It's because private providers are interested in providing relief to their customers, so to their patients, which then generates retention of their clients, their clientele, and their custom. And with retention then comes the revenue. The revenue is basically the core that these private providers are actually working for. And once they can build that sustainable business model, or that positive business model, then oftentimes these other factors come into play that often are overvalued or overestimated, but comprise an important point once the other 3 are covered, which is respect from the community and recognition, oftentimes also from the government, especially in governments like Vietnam, where it's a unitary system with a lot of central control, and being recognized by the government still makes a big difference. And lastly, in these collaborations, oftentimes reporting is critical for the National TB Program, but very much a pain for private providers. So finding a way to alleviate this pain point through NGOs like FIT is another benefit that this intermediary agency model can provide. Now, in return, what does the government get out of actually this type of collaboration? And it is basically expanding treatment coverage in terms of how many people receive high-quality diagnostics and high-quality treatment, getting a better understanding of the epidemiology. These prevalence surveys, as I mentioned in the beginning, are very expensive, and having a broader network that can provide you with more information automatically improves your understanding of your own epi in your country. Then I mentioned 2 of the key aspects. Finding these persons with TB and receiving the information is not enough. That's actually just the first step. The key here is to improve the quality of diagnostics and the quality of care. And so by linking up with these private providers who oftentimes do not rely on bacteriologic confirmation, or so sputum testing to get confirmation of disease, but oftentimes rely on screening tools like X-ray or even just clinical diagnosis, by improving and making available more better access to PCR testing, you can automatically improve quality of diagnosis and precision medicine. And then by providing guidance as well as the correct treatment regimen, as well as a way to transfer persons with drug-resistant TB into the formal DRTB treatment system, it automatically improve then thereby also the quality of care. And lastly, in doing all these things, you can cut down transmission, as we know, and by involving private providers on the market, you can also actually find a way to improve and gain access to alternative financing mechanisms, with the ultimate goal for both sides for this intermediary agency to help private providers meet their business objectives and help the government meet its public health goals, simply by referrals and notifications and by providing PCR testing and in certain times incentives. So we took this model and then tried to pilot it at first in 2 districts of Ho Chi Minh City, covering roughly a population of a million people, with around 1,200 or so persons with TB notified each year. And what we saw, what we wanted, the study or the research question, if you will, was very simple. Will private providers engage and participate? And then will that actually lead to something? As you can see here, we've mapped out about 1,100 private providers, reached out to reviewed these lists of, we excluded dermatologists and specialties that may not be a high priority, and then reached out systematically using kind of almost a pharmaceutical sales force approach to inform these providers, sign into agreements, and continually work with them to produce the public health outputs that we were hoping for, i.e. referring persons with symptoms, as well as reporting persons on private TB treatment. And as you can see here, in the end, about 126 or 12% of the number of persons, the number of providers registered, at least made at least one referral, and then we even had about 1% reporting private treatment. In terms of the referrals, this was quite a short pilot, but it resulted in about 5,000 persons referred to a X-ray facility, X-ray site. Of these 5,000 people screened by X-ray, and then accessing different types of sputum, different types of diagnostic tools. We, in the end, detected 162 persons with TB. And the surprising or not surprising part here was that actually 60% of these persons detected, initiated on treatment, were transferred to the NTP, but a large proportion actually preferred to continue on with the private provider with whom they sought health in the first place. Maybe not so surprising, maybe that's just human nature, but they decided to stay and then receive their treatment there. And that explains perhaps one of the large drop-offs in terms of the treatment care cascade. But amongst this 162 persons with TB detected, we were even more shocked about what we deemed strategy 2, or the private treatment reporting strategy, where these 14 doctors who were providing private TB treatment provided us or shared with us information about the patients that have come to seek care and have received treatment over the last 2 years. And that number, when the first number referrals was 162, this number was 1,112. And not only were these doctors sharing the information of these patients, or sharing that they are treating TB, but providing a lot of detail around the basis of diagnosis, around the type of TB, around the residency of the patients, even the treatment regimen, so that we could very quickly see, okay, many of these doctors are providing treatment in line with the national treatment guidelines, but then they make minor tweaks or go off of the treatment guidelines. And so giving us the information that we would need in order to come in and help or work with these doctors to improve quality of care. So these results were then translated. Unfortunately, we did this study kind of as a pilot without going through the full, and as a rapid pilot, without going through the process of bringing the national TB program on board and finding ways to actually get these 1,112 persons on private treatment notified. But what we did was model their impact and what their impact could have been had they been added to the routine public sector treatment notifications. And as you can see here, while the referrals resulted in a roughly 8-9% increase in notifications, had we added the 1,112 persons on TB in private sector, this could have led to a notification impact or increase of 68.3%. So based on these findings that we have published over the years, we have been able to find more support from various sources, institutional funders, starting with the Stop TB Partnership as the one that funded the pilot, over to receiving more funding from CDC, from USAID, and ultimately from the Global Fund, where we have gone from 2 districts in 1 province, over 19 districts in 3 provinces, and now are expanding this model this year to 15 out of 63 provinces in Vietnam. And so this scale up, if you will, measured from January 2020 until March, oh, I'm sorry, this is not March, I should say June 2023, it has resulted in us receiving the information of roughly 1,070,000 or 1,069,000 persons screened by X-ray, with around 11% of them tested by having a sputum test performed, diagnosing roughly 18 or 20% of those tested, and then linking to care roughly 19,900 persons with TB. And this is based on strategy 1, the diagnostic referral strategy. In terms of the strategy 2, the treatment, the private sector treatment strategy, but the initial 14 has now grown to about 133 private doctors who have unique private doctors on a run rate is roughly about 60 to 70, but unique private doctors who have notified almost 12,000 persons with TB, and going through, and of whom around 11,000 have been entered into the official surveillance system, given that after the pilot, we learned from that and then collaborated more closely with the National TB Program to actually report the persons with TB that receive treatment in the private sector. 2 of the things that I mentioned earlier, which is the focus on improving diagnostic quality as well as treatment quality, or here data quality, you can see that the strategy is, once the doctor reports to you somebody who's treated with TB privately, it is to help the doctor gain access to this PCR testing, which is not available in the private sector, and to make sure that at least for some, at least people initiated on treatment receive such a confirmatory test. And so we were able to do so in about 82% of cases, as our cutoff was within the first 2 weeks of treatment, given that after that, oftentimes the anti-TB medicines do their thing and are effective in removing TB from the sputum sample. But reaching about 82% with bacteriologic testing, and then detecting almost 7,000 persons with bacteriologically confirmed TB, of which roughly 2%, almost 2%, were actually drug resistant and then directly transferred to the national TB program, rather than having exploratory treatment within the private providers, as had been in the past. And then, as with regards to the 12,000 persons reported on private TB treatment, as the intermediary agency, one of the responsibilities is to make sure that these data that are reported to us aren't just blindly entered into the system, but a quality assurance process with various quality control steps and activities are implemented to make sure that these data are deduplicated, whether right when we receive them or within the first quarter, at the end of the first quarter, to make sure that they didn't go to the private provider and then jumped over to the public system and vice versa. But also verifying the veracity of the individual as well as the accuracy of the private information that they provided, in order to then share this with the government. One key here is that these data are shared obviously on a highly confidential basis on secure servers and secure systems, and without sharing who the notifying private provider is. That was one of the key requirements or conditions of these private providers to collaborate with us, that we don't divulge who they are that is treating. And that is another benefit of working as an intermediary agency, because the government also technically does not necessarily need to know who is reporting these persons with TB, just that they are reported and that they are put on high quality treatment. These efforts or these activities and these numbers that you saw were reflected even at the national level, if you will. So if, for example, in 2021, when we operated only in 5 provinces, that led to a total increase of 273% in the number of persons notified from PPM activities. But the bulk of that, as you can see, even though it was off of a small base, came from private sector notifications. But even if you look at the non-NTP public notifications, which comprise largely persons detected through strategy 1, that's still substantial, close to 100%. And if we then look at year 2022, the key point here is that the numbers increased, the percentages obviously went down, but not substantially. They're still very, very high, with a total increase of 84%, 56% from the private sector, and 118% from the public sector. But the most remarkable thing observation that we had was that even though this intervention, this project, was implemented only in 5 provinces in 21, in 10 provinces in 2022, the impact was actually seen at the national level in the green total rows, where in 2021, the national number of TPM notifications increased by 31% and another 62% in 2022. And that in the end translates to a little bit of this chart, where we see the numbers that I had reported earlier in 2020, roughly 12% coming from PPM in 2020, and that scaling up and increasing in terms of share or contribution to national notifications to 20% and then 25% in 2022. And that 25% actually, it's not in one of these slides, but I can share this, is what led to, in part, to a substantial and rapid recovery of Vietnam's case notifications post-COVID. And so, given that this model has created such a strong impact, we are hoping, obviously, that as we continue to grow, as we continue to scale, that it won't continue this hockey stick projection, but it will continue to show that we have a model that can effectively complement the national public response in order to make high-quality TB care and prevention available and accessible to persons everywhere in Vietnam. With that said, that is with regards to the impact of the intermediary agency on healthcare provision. Now, what I meant, or what I said in the beginning, is that you don't want to just look at what you have in front of you and how to work within the current paradigm, but see if you can actually expand the market and the paradigm in which you operate and get more actors interested in joining the fight against TB. And so here, for that, we've provided 2 case studies in terms of market shaping or market expansion. The first one is a collaboration that we've done with CDC, or through CDC support, with a local big data company, a private company of a large conglomerate that was interested in leveraging big data for healthcare applications, and worked with them to develop and refine a local solution for chest X-ray interpretation for TB. And the first step of that company is called VinBrain, and the solution was called Dr. 8, or is called Dr. 8. And the first step was to work with them just on something very high level, something very low risk, like a white paper, where we collected and compiled the information and drafted a document on the architecture of the software, on the process of its development, and then the intended use in Vietnam, which is for TB screening, as you can see here. And based on that white paper that was published in 2020, agreed, and based on that experience, agreed to work together on various ways of how to improve their software, help it become more competitive on the global market. And that included a first step of an initial benchmarking against 14 other softwares that we had benchmarked, or that we had evaluated to that point, working with them continuously through an iterative process of improving and measuring and improving and remeasuring their AI's performance, until we got to a point where we could perhaps even take it into the community for prospective evaluation. So as you can see here are the results for the first baseline evaluation. And as they say, nobody's born a hero, and neither are AI softwares. And this software basically came in ranking 13th out of the 15 we evaluated. And if you can see on the left side, this chart, this receiver operating characteristics curve, is typically how diagnostic accuracy and performance are measured, whereby a straight diagonal line would be a coin toss. And as you can see here, Dr. 8 wasn't far off from a coin toss. Now, that was the first evaluation, or the baseline. So then through this iterative process, we created a new library. They went back to the drawing board and refined the algorithm, and both sides continually to work and measure or benchmark their performance against industry leaders. to the point where this year, as you can see under evaluation number 3, it's found that their area under the curve was actually not statistically significantly different from the industry leader, that the next step is now to take this tool into the community and see how it performs under real world conditions. That was the end of my first case study. Now the second case study is basically looking at how can we, so this was a big data company that was interested in healthcare already. How can we get players from the private sector involved that have very little to do with healthcare? And so what we said is, one current problem we faced is that sputum logistics, or collection and transport, oftentimes takes up a lot of resources, and to be perfectly honest, low value resources, and then is oftentimes compensated using public health pricing mechanisms on a per sample basis. When in private sector, if you were to take this into business or into industry, nobody would pay on a per sample basis because it's just simply too inefficient. So what we did is basically we approached it conducting a bit of an internal evaluation using time and motion study approaches and procedures, and measured over 3 months and 14 staff members how much time each day and each week was spent on going to a place to pick up samples, then driving them to the laboratory, dropping them off, waiting for the results, or receiving results and communicating them back to the healthcare providers. And throughout this process, quantified the number of samples that were transported on average, as well as the amount of money or the costs that are oftentimes on average spent for each sample. As you can see here, it's 70,000 dong. At the time, that was roughly $3.50 per sample. And on these samples, clearly not every sample is created equal. Most of the samples are transported within a radius of 10 kilometers, and very few then go beyond that distance. But using this analysis, this internal analysis, we then went through kind of a vendor selection process, whereby through various sources of information, whether it's on social media, whether it's on Google, whether it compiled a list of around 150 rapid shipping providers, companies, private companies that basically within the confines of a province or a state go and then collect and ship packages. And then through a stepwise process, screened out those that didn't want to do anything to do with humans, biological samples, screened out those that didn't have the infrastructure, all the way down to those receiving quotations for certain ones that then will meet our needs in terms of business to business transport at the requirements and conditions of packaging and transporting and cold storing samples as required by the National TB program. Obviously, as I say that, we had to go back and work with the National TB program to make sure that the standard operating procedures for the sample transport was simplified to the point that these companies could actually participate in a cost-effective fashion. But long story short, at the end, what we found is that by not paying on a per sample basis and not having our own staff or public health staff do this activity, but outsourcing this business process to a provider whose main job is to do this low value work, we were able to reduce the cost or model out this cost reduction of around 78%. And now ever since have implemented this model and have seen that the cost reductions remain at around 60-70% compared to the old model. So in conclusion, I want to just wrap up today's presentation with 4 points. The first one is to make sure that in order to end TB, especially after a pandemic like COVID that wrecked the TB system in Vietnam, but also around the world, we need to make sure that we reach everybody, and we do so through an inclusive model that is able to work with and reach and engage private providers or providers outside of the system whose job it is to end TB, and make sure that both sides are able to work together effectively. The intermediary agency model that has shown in various settings, including India and more recently also in the Philippines, but especially also in Vietnam, shown to be that it's possible to operationalize this model effectively and to generate a value proposition that's beneficial to both sides and helping them to meet their business and public health objectives. And this next generation private sector engagement model, though, as I mentioned earlier, should not just focus on healthcare delivery, but also on market shaping, on making sure that we expand interest and involvement and lucrativeness or profitability of the market of TB and care and prevention for players that are not traditionally interested in participating. And so that at the end of the day, we have an ecosystem that can actually be more engaging across multiple types of stakeholders. And that usually is what then catalyzes policy reform and sustainability, and as well as obviously financing. And with that said, I really want to just quickly say thank you again for your attention, for the opportunity to speak and present to you today, and happy to take any questions you may have. Thank you again.
Thank you so very much, Luan, for the summary of the work. Fantastic to see it all presented together that way. I'm going to take the prerogative of the moderator to ask the first question, but I would like to remind everyone who is participating that you are welcome. This is interactive. You are welcome to come on camera or remain off camera and ask questions. If you would like to make an intervention or ask a question, just use the raise hand app, which is under reactions in your Zoom toolbar, to let us know that you're interested in talking. Once we get rolling, I'm hoping we can just chat informally, as we're a small group today. If you would like to make your interventions in the chat, please feel free to do so. You can either drop questions or comments in the chat. And if you would like to remain not for attribution, please target your interventions directly to me privately in the chat, and I will ask them without identifying you at your request. So I'm really interested in your thoughts, Luan, on some of these results are actually, I think, not what would have been predicted, and with a real world experience in the setting in Vietnam, particularly in urban settings. With your 3 case studies, which of the approaches do you think are extrapolable to other countries in similar settings? And then which of the findings do you think are just generally, it could be extrapolated for public-private mix in general, regardless of specific settings, and could be tested effectively in a range of countries with TB, mid to high type TB burden?
Thanks, Julia. I mean, at the end of the day, that is the big question. How can these learnings or this model be translated and scaled, perhaps, or replicated? And even though our goal is not necessarily to give out a model for replication, I think is the intention for public health interventions to actually, best practices to be scaled. And I think that of the 3 examples, the most, I want to say, generally applicable one would be the first, the intermediary agency model, and say that not just across geographies, but also across disease areas, that having a person or an individual or a unit that facilitates, that catalyzes, is generally should be translatable to other settings as well. The key here is to differentiate obviously between the local conditions, how big's the private sector market, how many, in Asia, there are a lot of private sector players, or in certain parts of Africa, and in certain settings, there are just none. And to then look at what is the mix between referrals and notifications, what are the incentives, or what are the private sector providers really interested in? In Vietnam, it was access to PCR diagnostics, as well as in the beginning, we started out with an incentive of $2 and nobody wanted to participate. And then we had to increase that because it was underpowered. But at the end of the day, the fine tuning will be setting dependent. But the model itself, I believe, is applicable to these other settings as well. Case study 2 and 3, that really depends on what the local conditions are in terms of the maturity of these private sector companies. Do you have an AI developer? Do you have a company like a rapid shipping and so forth? So that is more setting dependent, but it's case study 1 that I think can be translated to other settings as well.
Really interesting, thank you. And again, I would like to invite others to join. I see that there's colleagues here, CDC and former CDC colleagues on the call today. Also would love to invite any of my colleagues from CRDF Global to jump in as well. So just, I know that you have a hard stop and I don't want to keep monopolizing your time, but just another quick thought about the resources that it takes to scale some of these trials after testing. So you've demonstrated proof of principle that these innovative approaches involving private sector partners can work. And in some of the cases that the reduction in cost is really significant. If that were replicated more broadly, it would have a big impact globally on what kind of resources could be dedicated to other activities within TB. So I would love to hear your thoughts on scaling, because as you said, a lot of this is understanding the local market niche and finding the incentives that got those partners to respond. What are the challenges to scaling these programs in Vietnam or even beyond Vietnam?
I think as in so many other examples, the key to scaling is to pilot with scaling in mind, which means that you set up, you need, basically on a small scale, you can always ensure quality, you can always ensure fidelity to your procedures and so forth. But right from the start, once you understand the market and what, what incentives are sufficiently powered, what is it that providers are interested in or other players, then to actually then create systems and processes and procedures that are scalable. And so what I mean by that is to basically sit down and write a 100-page SOP to create a digital data collection system that works for 2 districts, so it works for 150 districts, to create the buy-in from not just the local provider or the local stakeholders, the local TB program, but also at the national level, across the spectrum of stakeholders. So I would say that we've also obviously been very lucky in that this model has garnered a lot of interest elsewhere as well. And for example, the scaling and the financing while we had to advocate with Stop TB or CDC or AID to provide the initial financing, the scale up to 15 provinces by Global Fund was actually, a lot of it was driven by them looking at the results, not just in Vietnam, but also in other settings. And so, part of it is being prepared. The other part is clearly taking opportunity of advantage of the opportunities that are presenting themselves, but just making sure that you, whatever you do it right, you do it correctly from the start and don't take shortcuts in the beginning because it is a pilot.
No, and that's a really good point, especially about being able to measure impact. What is the outcomes, defining the outcomes in the beginning.
The other thing I wanted to add to that is that we've also made a conscious effort to collect these data at a rate, as you mentioned, because you said the word impact, to actually then measure the impact and then publish these results so that you have the scientific or the academic basis, but then also go and do hand in hand with it all of these analyses that are related to cost and cost effectiveness, because at the end of the day, the government will always ask you, well, does it work? And if you can show that it works, they'll say, can I afford it? Can I pay for it? And even if you say, yeah, in the long term, it'll pay for itself, then most of the time they don't care about the long term because they might not even be in the position where they are at the moment to make decisions in the long term. So got to make sure that we have the ability to show that it works, and it's cost effective, and right now or tomorrow and next month it's affordable. And those are kind of the key issues that I think are also very critical in terms of if we talk about scaling.
Thank you so much. I would love to open the floor if anyone else has a question that they would like to ask or a point to make. All right, I will continue to fill the questions, but I again want to respect your time. I know that you have another meeting at the very top of the hour. So just I think a couple more questions or one more question for me. If anyone else wants to jump in, please, again, feel free to use the chat box or jump in either way. I think the point about proving cost effectiveness is a really important one as well, because when we talk about public-private partnership, everyone wants to talk about cost effectiveness, but it's I think a term that we use casually often without really thinking about what we mean in terms of cost effectiveness versus like cost utility or versus return on investment. Or we tend to, in public health, use those terms pretty casually. Given that you have experience in both the private financial sector and in the public health sector, what do you think is the biggest challenge in doing that last thing that you just highlighted? Convincing partners, whether they are government funders or international organizations that are propagating norms and rules. What is the biggest challenge in demonstrating, convincingly demonstrating that that those issues about cost, knowing that we often are using the terms very casually, very loosely, what are the convincing arguments, and what do you think really is a persuasive way to start looking at this public-private mix question as we move forward?
Actually, my first answer with that is actually that there is no one size fits all response. So that, oftentimes in public health, again, our perspective is the best, the be all end all would be cost effectiveness measures through incremental cost effectiveness ratios, using DALYs or QALYs, and showing that this intervention is actually much more cost effective than other interventions measured by perhaps GDP per capita and so on and so forth. I think that really resonates well with other academics and perhaps with other public health professionals, and even some of the political stakeholders that have a higher academic pedigree. But it's important to be able to basically have that in the back pocket, but also have a basic analysis, like you said, cost utility analysis. What is the cost benefit of this? We recently conducted an SROI analysis, for example. What is your return on investment? And we said, oh yeah, this includes the societal perspective and so forth. But in the end, if I say this costs $100 per person detected, the government usually pays $20 to $50. But active case finding with X-rays and looking for asymptomatics and persons without symptoms or contacts costs you $600 to $800 to $1,000. A simple cost benefit or cost utility measure like that, an argument like that, oftentimes works just as well. And then if you can say, on top of that, you don't pay actually very much out of your own budget in the near term, right? It's only this and this, or in the near term, it's about setting up the network. But now that the network's available, the marginal cost of expanding this, the SOPs are available, the marginal cost of expanding this model are actually minimal in the near term for your budget. That oftentimes resonates much better than saying cost effective and 1x or 3x GDP per capita or things like that.
Thank you so much. Appreciate that response. And I just want to make sure we give a chance if anyone else has a final question. Okay, you're getting lucky today because we do have a hard stop. Otherwise, I teach undergraduates and I have no problems just calling people's names and naming and shaming until a question gets asked. But I think today, given that, Luan, you've already given up your vacation to speak to us today, really appreciate your time. And I hope everyone here will join me in thanking you for the time you've put into that and for sharing these really interesting case studies with the group here today. So thank you so much.
Also, thank you and everyone for your time, for your attention, and giving us the opportunity to share some of these activities and results. Thank you again.